All right. So welcome everyone who is here with us live, as well as those joining us virtually. Thank you so much for taking the time with us to learn and get curious. Our focus today is supporting intimate partner violence survivors during the perinatal period. And we'll go ahead and introduce ourselves. I'm Paige Alia Hill, and I am a program manager with the Michigan Coalition to End Domestic and Sexual Violence. And my teammate today.
Hi, my name's Elizabeth Dodd. I use she, her pronouns, and I'm also a program manager here at MCEDSV. And I'm very excited to be here today talking about this.
Thanks, Elizabeth. Let's go ahead and jump on in. Of course, we have our funding acknowledgement here that in essence talks about where and how the grant is funded and specifies that the opinions and findings and conclusions and recommendations are those of Michigan Coalition and do not necessarily reflect the view of the U.S. Department of Justice or the Michigan Department of Health and Human Services. So always an important message to share where our funding is coming from, as well as grounding into where the messaging is from. So as we step on in, we wanted to start today by sharing a little bit about who we are and what our vision is, because we recognize that not everyone in this space today may know who the Michigan Coalition to End Domestic and Sexual Violence are. We refer to ourselves most often as the coalition, and I also recognize there's other coalitions across the state as well as nation. But our mission specifically is dedicated to empowerment of all of our state survivors of domestic violence, sexual violence, and human trafficking. And we work to develop and promote efforts aimed at eliminating all of these violences in our state. And we do this through our shared vision for creating empowerment and transformed individuals, communities, and societies committed to building a legacy of equality, peace, and social justice where domestic sexual violence and human trafficking no longer exists. So everything that we're doing today is directly connected to both our mission and our vision. It's something that we carry with us in our hearts and really permeates through all of our trainings. One other thing to note here is that we have member programs across the state, and we support those agencies that are serving survivors of domestic violence, sexual assault, as well as human trafficking. All right. So we want to start today by grounding us into a few things, as well as creating the container for today's learning. So when it comes to our guideposts today, I don't have a worksheet for you on this, but what we're really looking at is being open to new ideas, to new strategies, to new ways of thinking, even when it's something that we may not have considered in on our past experiences. So today is all about leaning into those curiosities and really doing a lot of self-reflecting, which may be a little bit of brushing up against the, oh my goodness, I missed something. We want you to know that's okay here. This is a space for making mistakes, learning, and doing better with what we learn when we take it away from this space.
I love how you
Um,
said that.
oh, thank
That's-
you.
yeah, I also think, this training hopefully is going to be a starting point. Like Paige said, you find areas where maybe you do need to learn a little bit more. Um, really understand like where areas of growth are, so that you can keep learning and investigating this important intersection.
Love that.
Mhm.
So that means we're normalizing our discomfort. In fact, we're leaning right into that discomfort in order to learn and challenge our own biases and taking that into the field with us to support survivors who are experiencing really challenging situations. So All of us in this space are here due to a live birth. What we may not know is what the individual who is birthing us experienced during their journey in pregnancy, as well as during the actual birth itself. So, as we're providing domestic sexual violence and human trafficking services to birthers, we want to recognize the unique needs of birthers at the heart of this. When we talk about birthers or pregnant person or parent or other phrases like chest feeding, we are working to honor and recognize that not all pregnant persons identify as female, as women, as mother, or as having breasts. So we're working towards acknowledging and respecting all gender identities. And you will see us use both gendered and non-gendered language throughout this training, and much of the research and the data presented are referring specifically to women or female identified pregnant or lactating people as well. Um, when it comes to gender, expanding our language is not invalidating or erasing the female experience or a woman's experience or a mother's experience. Instead, it is working to increase inclusivity and use the language, the pronouns, and the identities that survivors themselves are using for themselves.
Keep in mind today that this might be the first time that you're thinking about the connection between maternal health and interpersonal violence. When I first started working on this project, I didn't anticipate that being something that we worked on. And now I can't imagine how you can talk about interpersonal violence without also talking about maternal health. So, recognizing that typically we see this as a very joyful experience. We see pregnancy as something to be celebrated, but that is very much impacted by people's previous experiences with trauma and interpersonal violence, and even traumatic experiences with medical institutions as well. Keeping space for all the different spectrum of experiences.
Absolutely.
Mhm.
And while holding those different experiences, what we're working towards is a best practice of not holding judgment on survivors' choices and honoring their lived experiences. So I think that one of the things Elizabeth said is really reminding me of in my own advocacy work where I have focused more on birthers and those who are pregnant. And that has been like in the moment when they're pregnant. And usually it's at a time where like they've come to shelter with us. And so we're thinking and we're planning around services for somebody that's staying with us. Um, and one of the things that can get missed is how much trauma triggers these survivors can be facing while they're also experiencing a time in their life that could be or might also be intensely joyful. So they could have this juxtaposition, or it could be any variety and being weighed and held on them from those triggers from sexual violence or interpersonal violence or childhood sexual violence. In addition to those, we have additional layers from systemic racism, um, racism in the medical community, stereotypes, being excluded, marginalized, having a lack of validation of experiences, health inequities, and other harmful experiences, some of which Elizabeth had already mentioned. So what is really special is that here health workers, healthcare workers are in a unique role to support pregnant and birthing survivors and provide an empowering and healing experience for them in an effort to reduce the mortality crisis and the implicit bias within the healthcare and medical systems. So working to reframe and to center BIPOC individuals, disabled individuals, and LGBTQ SIA+ survivors. Oop, I'm jumping ahead without meaning to. Apologies for that. Elizabeth, did you have anything else you wanted to add here before we move to the next slide?
Nope. I'm ready to dive into an example to kind of show exactly what we mean when we say that interpersonal violence and pregnancy care are connected. So we have a fictional story, but it is based on common experiences. But we're going to read through this together, and I want you to look at all of the ways, all of the moments where someone could have checked in with her um, and tried to offer support. So she's a 28-year-old woman presented to her OBGYN multiple times during pregnancy with complaints of headaches, elevated blood pressure, and signs of anxiety. Despite these symptoms, her provider focused solely on managing her hypertension and didn't ask about her home environment or emotional well-being. She missed several prenatal appointments, which were attributed to transportation issues. After giving birth, she attended one postpartum visit where she appeared withdrawn and reported feeling overwhelmed. Again, no questions about safety or IPV were asked. 2 months postpartum, she was fatally injured by her partner during an altercation. A later review of medical records revealed missed opportunities to screen for IPV, which may have prevented her death. What
Mm.
stood out to you? What was a moment where, as a healthcare provider, you could have offered support? You could have been curious.
Feel free to put these into chat, and Elizabeth and I are happy to read them aloud too.
Mhm.
Thanks for adding that, Elizabeth. Elizabeth put the question itself in the chat. And while I am still speaking, I'm also going to mention that one of the things we do at the coalition is practice pauses. And generally, we call it the 30-second pause to give everyone space. And also, if you're typing, definitely the time in order to type in those responses. So please sit with us in that silence, allow it to be as we're thinking.
Yeah, silence is great. It means we're processing. We're thinking about this. And we have a few responses. Someone shared, I think a lot of people would not recognize the relationship between missed appointments and interpersonal violence. Absolutely. It was just chalked up to transportation problems. But what was a transportation problem? Was it someone controlling the means of transportation so she couldn't leave the house and isolating her? Someone could have checked in and asked more about that and if there were any ways to prevent transportation issues in the future. Someone else said, I think many people don't associate elevated blood pressure with traumatic stress like IPV. Absolutely. Absolutely. Dealing with the symptoms rather than what might have caused it, especially if it's something that you wouldn't automatically think of as a healthcare provider. And
Mm.
then someone shared,
Go right
I'm
ahead, Elizabeth.
I'm curious to know if other resources were provided or tests associated with blood pressure, anxiety, etc., and if provider thought this might be related to IPV or other trauma. Right. There's a lot we don't know with this scenario and a lot of different ways it could have gone. You know, it would be interesting to see what other factors are at play here.
I'm loving the questions coming in and the curiosities. That's exactly what we're hoping to start stimulating today. So thank you for all of this. Um, I'm wondering how we can learn more or practice skills around asking, talking, and screening for IPV. That is something that we are going to touch on today in this beginning stage of our training. And let's see. I think a lot of time blood pressure cuffs are sent home, but if the root cause is not being addressed, those things aren't as helpful. Totally. We have to think about those underlying causes. Absolutely. And additional folks in the chat not identifying other barriers to service other than hypertension, other health issues. Absolutely. And it's understandable that the focus is on those aspects. I think that's why you all are here today, is to gain more information and more knowledge about how IPV might be showing up in these spaces. That last comment, the root of the matter goes much deeper. I love that.
Yeah, and I just think, did anyone check would it have made a huge difference if someone had just checked in and said, like, "How are you? You know, I'm noticing this, like, let's talk about, like, how you are," not just like a checklist on a form, not just like in the context of like your health journey, just like, how are you as a person, and offering that moment of connection, just how much that would mean,
I
what that could
know
have
that,
led to.
yeah. And I know that it can be challenging with additional pressures in systems, in our healthcare system, to move folks through their appointments at a particular pace. It's very common that like there's a certain amount of time. And so sometimes these kinds of humanizing questions can be missed. And so what we're encouraging is taking the pauses and bringing them back in. And we're going to talk about why this is so important, beyond our hypothetical situation here. Um, the injury and the mortality rates, and the dangers for pregnant people, for birthers. So let's go ahead and dive in.
Yeah, so this subject, it's not just like an additional aspect of care. Like this is healthcare, screening for interpersonal violence and offering that support. You know, the health consequences of interpersonal violence in pregnancy can be delayed or no prenatal care or missed appointments, which are incredibly crucial at such a vulnerable time. I don't have to tell healthcare practitioners that. And then an increased risk for postpartum depression, anxiety, and post-traumatic stress disorder. For the baby, it can lead to preterm birth and low birth weight, and it can cause an increase in substance use, which can
These
also
are
cause.
just some of those consequences that I was referring to on that previous slide, and we're going to dive into more of the data around this as well. Um, Before we do that though, let's introduce some like terminology, because we keep talking about interpersonal violence, sexual violence, domestic violence, and we want to give you a definition of what domestic violence is in order to create that shared understanding, not only in this space, but as you continue forward in your practices. So, right here on the slide, domestic violence is a pattern of power and control that one person exerts over another, carried out in several strategic ways.
I don't know if anyone's like me and you'd originally heard of domestic violence as a cycle. That is not something we use anymore. We use a pattern very intentionally. Uh, you know, with a cycle model was very much like there's a honeymoon stage, tension building, and then an explosion, like these three parts. But that isn't true at all because each pattern is unique to every relationship. There aren't necessarily like a safe stage. And there's also this idea of the honeymoon stage as being like, again, safe or a positive thing, but it's all part of it, all part of the abuse. You know, if you live with a batterer, you live with him every day. Even if he's being nice to you, it's all part of the violence.
And this includes the more visible aspects of violence, as well as the less visible elements to control and maintaining power, which includes like financial, and of course the more visible actual assault, physical assault. So we know that the elements of inner personal violence are criminal and non-criminal in nature. So we want to dive into this a little bit further. We're going to start with a video. Elizabeth, what do we want folks to kind of be thinking about and brainstorming while we watch this video?
Yeah, just what tactics do you see being used by the perpetrator to exert power and control?
So feel free to keep these in your mind, or if you have a little piece of scratch paper, you might want to jot some things down. All right, I'm going to go ahead and play. Elizabeth, will you give me a thumbs up if the sound is good?
You ready?
Yep.
And for the rest of my life, I don't want to be with anyone but you. What are you doing?
Until death do you part.
I do. Well, maybe I wouldn't have to worry about other guys looking at you if you didn't dress like a whore.
I just don't know what I would do if you were with anyone but me.
Where you been? Hey, you look at me when I'm talking to you. Do you hear me? Look, I didn't want to do that. But you just don't listen. Who's that?
Hey! You sure you're okay? I'm fine.
Who's gonna take you in but me? You will never see your son again. How about next time? I make sure you never leave the house again. Guess it's my lucky damn day. Look what I found under the bathroom sink.
Johnny, wait, just, no, hold on!
YWCA hotline. How can I help you? Every day, 24,000 women are abused by someone they love. Just one phone call can help put a stop to it.
All right, so intense video. Take a breath and kind of take a moment to settle back into ourselves if you're also feeling that heaviness. So what we want to start with is that question that Elizabeth asked, which is what tactics did you see? And I'm seeing some things popping up in the chat, but we're also going to play with a Mentimeter today, which if you have experienced Mentimeter before, welcome back. And if not, what we do for this is you have two options. You can utilize a mobile device to snag that QR code and go to the Menti itself, or you can use your computer, your desktop, top, and go to menti.com and then enter the code that you're seeing on the screen. Now, if you are tuning in after to the recording, the Menti will not still be live, but you'll be able to watch here and see what the results were in this space. So we're going to make sure to keep sharing that here. So I'm seeing folks popping into the Menti, and I'm going to go ahead and go to that first question. And while you are typing in responses to what tactics of abuse did you see from the video, I'm also I'm going to share one comment that was already posted into the chat. In our chat, it says, it's really powerful to see the progression from what the general public may consider a, in quotes, normal, healthy relationship to the bruised face making the call. It's difficult to understand how someone arrives at that last moment, and it's helpful to see that it's a progression. It didn't start that way. Wow. I think that's a really powerful summary of what we witnessed, and a reminder that we can always keep that humanity at the heart of things when we're in spaces alongside people. That what if there is something else that's going on here, rather than making an assumption about someone. Thank you for that comment. Elizabeth, what are you seeing popping in that's grabbing your attention here? We've got lots.
Is it actually possible to zoom in a little bit? I'm having a hard time reading it.
Oh no.
Oh, okay. Never mind. I was able to do it on my end.
Oh, you were okay. I was like, good. I'm glad you found that button.
Yes, isolation is huge. You saw in the video, he said, you won't see your friends and family again. You know, creating a disconnect between someone and their support network from their community, it allows the perpetrator to exert even more control, to have even more power over this person. It gives the survivor less options for support.
Mm.
Testimony of love. That sounds maybe like love bombing.
Mm.
Yeah, kind of like an emotional abuse um, to kind of disorient someone and to keep them in the relationship, if that's fair to say. And then verbal abuse. He was calling her names, he was degrading her, all these things to erode her sense of self and self-esteem.
Because we're getting so many responses, I am going to group some of them. Let's see if this will work. Oh, no, AI tools not available. That's okay.
So you can like verbally group these. Because I'm seeing a few, like not letting her leave, part of that control and that isolation. The physical violence, we saw very clearly. Manipulation disguised as loving statements. I think that goes with the testimony of love.
Mm-hmm.
And that moments of normalcy, that manipulation. I'm always so struck when I see this video because it is just so, I get whiplash watching it because there's just so much happening. It's so disorienting to see one extreme and then another extreme. And I think that it's really powerful that it puts you in the shoes of a survivor to be able to understand a little bit better what that experience could be. The controlling finances. You look and like she doesn't have a wallet, she doesn't have cash in her purse, she's trying to hide money, but he ends up finding it. When you don't have control of the finances, you don't really have power, you don't really have options.
And how many of these things can we see? Like if a survivor walks into space with us. Yeah,
Yes,
that chat came in. Elizabeth, you want to read that one? It's powerful.
I think we'd only see the bruises as a provider.
Yeah, I think you are very right.
Mm-hmm.
All right, so we've named a lot of tactics here, and these are not isolated or only one person's story. What we want to take a look at is a tool that we have also provided in the chat, a link to it. This is the first link we provided, and if you're tuning in later, we'll make sure that this is attached. It is the Power and Control Wheel.
Yeah, so this wheel was created through listening sessions with survivors. So it is a graphic showing all these different tactics that people were sharing. These aren't all the tactics that perpetrators use by any means, but these are some of the core ones. And I want you to notice with the setup of this wheel that at the very center always is that power and control, a desire to exert that power and control over another person. And then on the outside, you'll see physical violence and sexual violence. That is always the ongoing threat that's happening. When you look at all the other different spokes on the wheel, that's also the threat that it could escalate to physical and sexual violence. So a few of these already came up, but I was thinking we could go through the spokes here.
Oh, I switched, sorry.
You're fine. Okay, so we have using intimidation, making you afraid by using looks or gestures or actions, smashing things, abusing pets, displaying weapons, all these things to say that if you don't follow my rules, there is this threat of violence and of to scare someone into submission. And we have emotional abuse that came up a few times, which is those like name callings and put downs, all these things to make you feel bad about yourself and to erode your self-esteem. It also could involve making someone feel responsible for the abuse.
Mm.
And I'm going to try to pause after each one so folks can share anything else that comes to their minds while we're talking. And then we have isolation, which can also be social abuse, which we talked about was removing a survivor from their support network. That increases the perpetrator's control. It could look like restricting someone's car or taking away their car keys so they can't leave the house. They can't attend appointments. They can't connect with other people. And we have denying, minimizing, and blaming. All of these things to make a survivor question their experience. This can also look like gaslighting, or you might have heard the term crazy making, twisting things so that just enough, subtly, so that a survivor questions their own experiences, their own judgment, their own reality. Again, giving the perpetrator all of the power to create the narrative. And someone shared, now that we're reviewing this wheel as a provider, I might not even see the bruises. I might see nothing because she skipped her prenatal appointment that day, so I didn't see the bruises. Thank you for bringing that in from our earlier scenario, our earlier vignettes. Transportation issues could have been someone taking the keys, restricting her access to the car so she couldn't go. But that's not something you're going to see on your end, not unless you ask and you're curious and you create a safe environment for them to talk to you. We also see perpetrators using children to manipulate the victim. So making you feel guilty about the children, using the children to relay messages, threatening their safety, threatening to take them away. And we have using privilege. So, in this example, I think they were originally talking about like using male privilege, understanding that there are these power dynamics that they can exploit and that they will exploit. So treating you like a servant, making all the big decisions, being like the head of the households, using their privilege to bolster their credibility and to discredit you, to cut you off from resources. And again, just using that power dynamic, those systems as a weapon. And again, in this original version, it was around male privilege, but that goes for all areas where someone might hold privilege. People can weaponize and use their white privilege. They can use their heteronormative privilege. There are many different ways it can be weaponized. And then we have using economic abuse. So preventing you from getting or keeping a job, making you ask for money. Again, they are completely controlling the household finances. And using coercion and threats. So making and or carrying out threats to do something to harm you. It can be threatening to leave or to end their life, driving recklessly to frighten the survivor. All of these things that helps them get the outcome that they are looking for. And I think a lot of that already came up in our Mentimeter. So unless there's any initial questions, we can move on to the second question here.
Back to the Menti.
Mm-hmm.
All right, now we're ready for that Menti.
Okay, and I feel good. We got all those tactics did come up from the original question, but now I want to ask, what could these tactics look like in the context of pregnant and birthing survivors? So what would economic abuse look like in this situation or in this context? What does emotional abuse look like in this context?
And as you're thinking about this, I did also drop a second link to a slightly different power and control wheel, and we will be bringing that up on our main screen in a little bit, but feel free to reference that as you're thinking and contemplating this question.
I'll put it in the chat too. You already did.
That's all right. Thanks, Elizabeth.
Mhm. Not allowing payment for lactation supports, absolutely. Controlling which providers someone is allowed to see, absolutely. Taking away a survivor's agency in a way that is going to affect their health. Not allowing attendance to prenatal appointments. And delayed care or no care at all, that could very much so lead to healthcare complications. Pregnancy is a very, very vulnerable time. Denying access to nutrition. Body shaming. Absolutely. That emotional abuse, tearing them down. Manipulation, twisting the words of the survivor at appointments. Threatening to hurt the fetus. All ways to exert power and control. Forcing an abortion, not allowing an abortion. Again, taking away a survivor's choice through that coercion. Getting them pregnant right away past birth, post-birth.
Maybe she's pregnant because of rape or messing with contraceptives. Yeah.
Yeah. Sexual violence can happen in interpersonal violence relationships, and someone's pregnancy might be the unintended consequence of sexual violence, which is going to change their experience of pregnancy. The bad mother trope, shaming them, saying that they'll be a bad mother and that they can't be a parent.
And then once the birth occurs, continuing that trope.
Giving another brief silence in case anyone has anything else to add. Expecting money to buy things she needs during pregnancy, feeding, care, etc. Yeah, she's not able to buy the survivor's not able to buy the things that they need to be able to care for their child and for themselves.
Restricting money. There we go. That makes sense. Had a little typo in the comment here. Restricting money to buy things. Yeah. I think Elizabeth interpreted that one correctly.
So keeping all of this in mind, I want to ask, what do survivors need from you as a healthcare professional? And these can be very simple, very human things. Support, referrals, belief. Just saying, I believe you and I hear you could make a world of difference. There is so much victim blaming that survivors have to combat. And every time you're able to say, I believe you, I trust your judgment, you're combating that victim blaming and you're offering support, empathy, listening to understand, giving that person the time and your attention, offering support, offering referrals, knowing the resources around you, what kind of services could be helpful, and being able to provide that. Care, absolutely. Care for their physical health, care for their emotional well-being, care for them as a person. Giving that 30 seconds in case there's anything else.
And if you're having any troubles with the Mentimeter itself, or if it's limiting you on how many answers you can put in, feel free to add some more into our chat space as well. Because I know there's more folks trying to participate, and I think we might be having a little glitch with our Menti. There we go. Uplifting, non-judgment.
Patience. Creating a safe space for someone to share their experience and what they need, without judgment, without assumptions, and without rushing them. Information. Not just referrals to resources, but actually being able to give like tangible, helpful information that they can use, or even just like a starting place so they can better understand their experience, showing them the power and control wheel so that they can understand and process the tactics being used against them. Flexibility with scheduling. Talk to an advocate in my office after an appointment.
Absolutely. There are advocates across your communities who absolutely want to be there as a resource to you.
Talking to them away from their partner if they're there. Absolutely. They can't be honest in front of the person that's harming them. And you don't know from the outside if they're in an abusive relationship. So making a standard practice to talk to them alone is going to give someone the space to be able to disclose if they need to. Giving space for any final thoughts. But it can seem like such a huge task to support someone who's experiencing interpersonal violence. And we might want to maybe like jump in and like fix the problem or save them. But, we can't do that. That's not our role. But these are all very achievable things that we can do to offer support. It doesn't take too much effort to listen. It doesn't take too much effort to believe someone, to be flexible with scheduling, and to make these tiny shifts that are going to make a huge difference for survivors that you're working with, that you might not know you're working with and caring for.
There was one you mentioned early on, Elizabeth, based off of what somebody posted in this word cloud. And that was around trust, like telling them that you trust them with like knowing. That is something that I only like personally recently experienced in a medical space, and it really shifted. And this was just a general general appointment, and it's like for me felt I felt more confident than in saying like what I was thinking and needing and looking for.
I mean, I'm sorry that only happened once, but I mean, it's such a it's such a meaningful experience though when people do take that time and they do that. They build that relationship.
Yeah, it's seemingly simple, but like hearing that, I needed it in the moment. So I can only imagine how much that can support, and not only imagine, but I know how much that can support.
I know I feel like it's common to feel like you know, you're there to answer the doctor's questions, you're there to make the appointment go smoothly. That having a healthcare provider who makes it very clear that they're there for you and this appointment revolves around you, it just changes everything.
Let's go back to the power and control wheels again, visual, and maybe the second one. So we definitely were landing both in the chat and in our Mentimeter on some real specifics that shift when it comes to birthers and childbearing years.
Yeah, sorry, I had to zoom in here. But yeah, so you'll see a lot of the same things, but in this context, financial abuse could be denying access to adequate food or support for a healthy pregnancy, making the parent work despite concerns for their health, and refusing to pay for child-related expenses. Coercions and threats. So threatening to leave if they don't do what you want them to do, if they maybe don't end the pregnancy, or if they don't have the child. Threatening to harm them if they tell anybody about the abuse, or threatening to harm the baby. And then sexual abuse also came up in that could be the cause of an unwanted pregnancy through the direct means. But it also can include things like messing with someone's birth control in order to force them into pregnancy, always taking away that autonomy, that agency, and making the decisions and having the control. Minimizing, denying, and blaming, holding the survivor responsible for the pregnancy, refusing to admit that maybe they're the father of the child, and maybe blaming the child for being the wrong sex. All things to constantly put blame and shame on the survivor. And then physical abuse, so increasing the severity or the frequency of physical assaults, you know, specifically directing physical abuse towards their abdomen and or their genitals, or interfering with breast or chest feeding. So forcing them to, even if maybe that is something that's uncomfortable or triggering, or not allowing them to chest feed or breastfeed, which, you know, if that's something that you want, that impacts your relationship to the child. And again, it's about controlling another person's body instead of letting someone make the decisions for themselves. Using children, threatening to harm their child should they decide to leave, and trying to convince others that they are an unfit parent, that they're a bad parent, or threatening to involve child agencies like CPS.
Right back to that trope that we were looking at on the Mentimeter.
And then emotional abuse, the body shaming someone mentioned earlier, making derogatory comments about their changing body, verbally shaming them for being unable to maybe care for themselves during pregnancy, and sabotaging their efforts to reduce or eliminate substances that may be harmful to themselves or the developing baby. And then weaponizing privilege, specifically weaponizing male privilege, demanding that she care entirely for the infant and the households, not offering any support or help, and asserting that the child will be raised according to their customs and belief systems, and just demeaning their role as a mother. And again, isolation, that prevention from getting prenatal care, prevention from accessing information about their pregnancy, and refusing or interfering with their contact with family and friends. It takes a village to raise and support a child, and they would isolate you from that village and from resources.
So we can see that there is a lot of overlap of this wheel to the more general wheel, but we can also see how some of these tactics are really unique to childbearing years. And something else we want to draw your attention to is that while one of the best predictors of abuse in pregnancy is previous abuse, as many as 40% of those who report abuse in pregnancy stated that the abuse started once they became pregnant. So abuse in pregnancy involves tactics that are absolutely unique to the childbearing year during a time when birthing people are more physically and emotionally vulnerable.
Yep, they'll see how unpredictable pregnancy is and use it as an opportunity to leverage more power and control. It always surprised me when I first learned that abuse can escalate during a pregnancy, because I feel like in media and just in daily life, there's this narrative that if someone is pregnant, that they are protected from abuse or they're like off limits. And to know that not only is that not the case, but it's the exact opposite, that abuse can start or escalate during pregnancy, is something that always takes me back a second. It's not common knowledge, but it should be.
This also brings us back to the question that Elizabeth posed, which was like what you can do as a provider, because we can, as we look at this, we can make connections between what might trigger trauma and that connection to power and control. So for example, somebody of authority coming into a space. So like your healthcare provider coming into space, and whether you're offering informed consent versus informed decision making. So those interactions that survivors have with healthcare providers can absolutely cultivate trust in a relationship or not.
Say they might seem like small choices, but giving choices wherever you can is huge. You know, that's a way that you restore someone's autonomy and agency after it is continuously violated by violence. And being aware of the power dynamic between yourself as a healthcare provider and the person that you're caring for. You know, it might not feel like it, but you're an authority figure. So being able to be aware of that and to mitigate that power dynamic a bit is very important, especially for survivors.
Pausing for a moment to see if there's any additional comments, questions. But I think we can move to the next slide. Yes? All right, let's do it.
So yeah, it's not uncommon. Each year, an estimated 324,000 pregnant people in the United States are battered by their intimate partners. And again, many survivors report that abuse either began or intensified, or maybe became physical for the first time during pregnancy.
We talked earlier about this, but it's always really important to keep in mind that intimate partner violence, it can be associated with coerced, unwanted, and unintended pregnancy, as well as delayed perinatal care. So keeping these in mind, smoking, alcohol, and substance use as well. So just keeping all of those things in mind.
Mhm.
The what ifs.
But you can see it's a lot more prevalent than we give attention to the problem. And I think there's this idea that domestic violence is between the couple, that it's kind of private, but it's not. It affects all of us, it affects our communities, and it's everyone's responsibility to be aware and to offer support.
And I think we also talked about earlier the impacts as well on infants, but infants that are exposed to IPV can show signs of trauma, including eating problems, sleep disturbances, and higher irritability, as well as delays in development. So those are also things to keep in mind. These harms can be mitigated by the presence of a secure relationship with a safe caregiver as a part of that support system.
Absolutely. And then I think on the next slide here, we have some statistics again showing just how prevalent this is and kind of painting a picture of what this looks like specifically here in Michigan. So between 2017 and 2021, there were 55 homicide cases among maternal deaths in Michigan. Intimate partner violence was identified in 12.3% of cases, and 36.4% of those involving a partner listed as the perpetrator. The data shows that Black mothers are disproportionately affected by interpersonal violence. And violence was a contributing factor in 15.2% of maternal deaths, and all of these were considered preventable. And as we know, the most dangerous place for a pregnant person is inside of their home. Again, that social script that a pregnant person is protected or is off limits is not true whatsoever. But when we look at maternal mortality, it's not just because of perpetrators. It is also because of risks and implicit bias in healthcare that can be harmful and inequitable. But that's why it's great that y'all are here for this training so we can talk about the opportunity that everyone has to take on an active role in mitigating those risks and making appointments and medical care a safer space. On the next page here, you'll see some of these contributing factors.
Yes. So this slide is highlighting key contributing factors associated with intimate partner violence. Circling back to the most dangerous place for a pregnant person being inside their home. And there are active ways that as healthcare providers, you can support and mitigate some of these risks that are listed here. So it is really important to recognize that these factors often overlap and they rarely occur in isolation. And the top contributing factors identified in IPV cases are assessments, which you can see in 50%, This can include failure to screen or inadequate assessment of risk. Environmental factors is another one. That's 35%. This can reflect stressors in the birthing person's social environment. Those stressors are significant. Social support and isolation. This can include the lack of family or friends or other supports, community supports, all of that. Discrimination, and we're going to talk more about discrimination on the next slide also. That's also at 35%, as was social support and isolation. I forgot to say that. Clinical skill or quality of care at 30%. This is where personnel were not appropriately skilled for the situation, or they didn't exercise that clinical judgment with standards of care. And then we also want to mention referrals here. So also 30% referrals were not made. So again, this is highlighting many of the contributing factors from the earlier narrative, that story that Elizabeth shared, where we were talking about and looking at some of the common experiences. So we want to spend a little bit of time looking at the inequity specific to maternal health care and the disproportional victimization rates, and why it's so important and why we center BIPOC, disabled, and LGBTQ plus survivors. So we want to look at this in terms of intersectionality. This is the understanding of the interconnected nature of social categorizations, right? We love to categorize things, but for these, we're looking at all of these different areas on this chart, race, class, gender, as they specifically apply to a particular individual or to a group. You can look at it both ways, regarded as creating the overlaps or the intersections and an interdependent system of discrimination or experiences. So marginalization that occurs as a result, or privilege that occurs as a result, and recognizing that different people experience different types of marginalization and privilege throughout their life. So when I say something like that, some things change, right? And some things stay the same. So like our age, that changes, our occupations, our educations can change. So this can shift for people. So when we're looking at intersectionality, this term was coined by Kimberly Crenshaw. And we are looking to return to this framework whenever we're speaking about survivors. Like earlier, we said we can't always know by looking at someone what they're going through. We also cannot make assumptions about what somebody's intersections are until they tell us. So it's important to understand this in healthcare provision, as some identities may have really different responses. Some cultures have really different responses. And systems have not been kind to many people of varying identities. And that includes those who are experiencing, for example, like economic hardship. And income is on here as well. So when we're talking about reproductive justice, there are several areas that we have to look at. We have to look at power systems. We have to look at the history of this and the acts that have been based on gendered, on sexualized, and on racialized acts of dominance. So again, power and control comes into impact what intersectionality is. We have to address intersecting oppression, so those multiple layers. Marginalized women face multiple oppressions, and we help to reduce barriers by addressing how those can impact one another. We also need to center the most marginalized. Our society isn't going to be free until the most vulnerable people are able to access the resources, the healthcare, and the full human rights to live self-determined, autonomous lives without the fear or the discrimination. And we have to join up across issues and identities. So recognizing that all oppressions impact our reproductive lives, and the intersectionality approach is both an opportunity as well as a call to come together as one movement, regardless of our different roles, our different jobs, our careers. It brings us together with the power to win freedom for all those who are oppressed. And it also addresses the needs and issues of a diverse group of people, while acknowledging the layers of oppressions that our communities face, particularly those who don't have access to privilege, to power, and to resources. So we want to look at another layer to intersectionality here, and that one isn't listed on here, but it is yet another stem off of this, and that is pregnancy, birthing, parenting as primary identities, and then consider adding additional layers of identities and lived experiences. So, for example, drug and alcohol misuse could be there. Maybe it's somebody who is a recent migrant or an asylum seeker. They could have a current or a history of domestic violence, sexual assault, or childhood sexual assault. They could be unhoused, or they could have unstable housing, underinsured or no insurance. That can play an additional impact. Other traumas, mental health struggles, whether they're diagnosed or not, if they've experienced trafficking, if they've been involved in the criminal justice system. What do the financial needs look like? Disabilities, non-apparent disabilities, current involvement with social services, if they have other children, perhaps. All of these layers. Again, it's really keeping that open mind to the what ifs and the layers of people, and not making those judgments on them, and recognizing that human beings are complex, and they bring experiences into offices with us.
That was beautifully said. And this slide here, where we're talking about healthcare screening for interpersonal violence, is one way that we can not make assumptions and meet people where they're at. So, it's pretty common for people to maybe feel uncomfortable talking about domestic violence or sexual assaults, especially, if you're not an expert in it, or you haven't received any training. But it is so effective in supporting survivors. It can make such a huge difference that we have to get comfortable talking about domestic violence, talking about sexual violence. And that's why instead of like a model where you're screening for domestic violence, if you hear like a red flag, or if someone discloses something that kind of triggers additional questions, you should be asking questions to everyone who comes into your office to, again, screen for domestic or sexual violence. Instead of asking, are you experiencing domestic violence? Think back to those tactics that we saw, and ask specifically, like, is your partner controlling all of the money? Are you experiencing economic abuse? Giving definitions so people can visualize it and picture it, because we all have ideas and stereotypes about domestic violence that sometimes might make it hard for us to see our own experiences. But when you screen in a way that is descriptive and without judgment, then you give an opportunity for that connection and for that check-in.
We have a video. Elizabeth, do you think we have time to share it in this space, or should we send it after for folks to utilize as a tool?
Can make time for it.
All right, I think
So
so.
2 minutes.
Yes, yeah, it's pretty short. But before we do, we've got another comment. I know that screening is often a requirement, but providing everyone the information, universal education is so helpful to get the information across. Thank you for sharing that. That is absolutely what we are looking at here, is that universal lens. So let's go ahead and dive into that through another video. So this is an example of a trauma-informed, survivor-centered universal healthcare screening for IPV. You're going to see a couple of different examples of lesser survivor-centered trauma-informed practices, and then the universal healthcare screening will be on here. So there's 3 different examples. And Elizabeth, if you would give me that thumbs up again when you're hearing it.
The following video was developed by Futures Without Violence. This video was produced by the Reproductive Health National Training Center, RHNTC. Universal Education and Screening for Intimate Partner Violence in a Reproductive Health Setting, a demonstration. Staff and providers often directly ask clients about intimate partner violence, or IPV, but data tell us that disclosure rates tend to underrepresent the true number of clients experiencing IPV, and we know that clients may have a number of different reasons why direct disclosure is hard. Using evidence-based IPV screening has been the standard of practice in most reproductive health programs for decades. Before we learn about a different approach to IPV screening, let's take a look at 2 examples of how evidence-based IPV screening can look.
So, everything looks great. I was reviewing your medical history, and I saw that maybe you didn't have enough time to complete all of the questions that were on the form. So, I wanted to ask you, have any of your current sexual partners made you feel threatened or afraid?
No, not at all.
Okay, good. Have any of your current sexual partners hit, choked, or physically hurt you?
No.
Have any of your current sexual partners forced you to do something that you didn't want to do sexually, or refused your request to use condoms?
Not even.
Okay, good. I'm glad. It sounds like you're in safe relationships. I did notice there were some other questions on the form that were left blank, so I just wanted to check in with you about those as well.
I was reviewing your medical records, and I saw that maybe you didn't have enough time to complete all the questions. Is that something you missed, or something you wanted to talk to the clinician about?
Oh, sorry, I just missed that one. So, no, is nothing going on.
Okay, great. Then I will just check no for you on the question.
Thanks.
Yeah, no problem.
We just saw 2 different approaches to screening for IPV, both of which were based on a provider or staff member directly asking the client about IPV. As you saw, neither of these scenarios resulted in disclosure. How often do you get a disclosure of domestic violence or intimate partner violence? Daily? Weekly? Monthly? Quarterly? Likely, based on the research, most of you are seeing very low disclosure rates. We know young adult women using family planning clinics report higher rates of IPV compared to their same age peers, in some settings as high as 53%. So we know IPV is taking place at much higher rates than clients disclose in our settings. Research shows that about 64% of transgender individuals report sexual assault in some point of their lives. Let's consider why disclosures may be difficult for clients. Research tells us it's a myriad of things: feelings of shame, concerns about child welfare involvement, and concerns about judgment on the part of the provider. In rural settings, clients may have concerns about who will find out or confidentiality. Lastly, long-standing issues for clients of color that have experienced racism within the health system and have a distrust of medical services generally. Given the realities of low disclosure rates and recognition of the barriers for disclosures, how might we enhance the work we have been doing to address IPV in reproductive health? Universal education prompts providers to give information about and resources for IPV to all clients without first requiring disclosure. This approach normalizes the prevalence of IPV and how to access help for yourself or others. Let's look at a different approach that can enhance your IPV screening.
Before you go, I want to share these cards with you that I give to all my clients. I give everyone two so that you have information for yourself and so that you can share one with a friend. We all know someone who has struggled in a relationship and we weren't sure how to help them. So it talks about relationships and what we deserve in them. Respect, kindness, no pressure to have sex. And it talks about situations with partners who may try to hurt or control you. Now on the back, there's a number for a free, anonymous 24/7 text line where you can text to get information or talk about relationships. Is this something that you'd be interested in taking a look at or taking a photo of?
Yeah, this is good. Yeah, I actually know someone who might really need this, so thanks.
In this session, we saw the provider offer information to a client up front without needing the client to disclose first. This is what we call universal education, giving information to all clients up front without requiring disclosure, since many people who could benefit from the information might not feel safe or be ready to disclose. It took about 45 seconds. Let's consider why this might be empowering for the client. What happens when we frame the intervention around two cards so we can help others? Research tells us that this approach normalizes the encounter for the client. By not having the focus solely on them, they can feel free to take the information, even if it is for themselves. We also know that treating clients as allies who can help others is something that can be profoundly beneficial and meaningful for our clients. The client feels respected by the provider, so this approach has multiple benefits. Every client gets resources they may use for themselves or may use to help others, and providers have a sense they may be increasing their own impact as a result. It ensures everyone leaves with resources, even if they can't or don't feel comfortable sharing their stories with us. This approach puts power in the hands of the client. Disclosure stops being the trigger for referral, and universal education assures that every client has referrals.
Learn more at rhnTC.org.
All right, so the first two examples in this video were potentially problematic, but that third example again is a good example of trauma-informed universal screening. Something that we like to highlight here too is while screening in this way may seem intense or maybe out of boundaries, or too time consuming to conduct a trauma-informed screening or respond to a survivor disclosure, as we can see in the example, it's just 2 minutes. But it also means that we have to know or have knowledge in healthcare systems about what is available. What kinds of resources are out there? How do we engage the rest of our community in order to have good outcomes and not be like, uh-oh, now what? On that kind of deer in headlights moment.
Which brings us perfectly into our next slide here, talking about resource referrals. So like Paige was saying, like, it's so helpful and important to understand what services and resources are available in your county, in your area, so that if someone does come to you and asks for some specific service, you know where to direct them. And even better, if you have a relationship with these agencies, if you know specific advocates, then not only can you give a referral with specific information about that agency, but you can directly connect them to an advocate that you know, that you can introduce them to, and just make that even easier and supportive in such a vulnerable time. When you're giving those resource referrals, you also want to make it a conversation. You don't want to just give someone information about a service and then keep it moving. You know, you want to ask, like, is this something that you're interested in? You know, to see if that person actually wants that resource. Maybe ask, do you have any hesitations about reaching out to this resource? And then someone might tell you about a barrier, and you can work together to figure out maybe a better resource or how they can navigate that barrier to still access services. Letting them know that you are there to support them, and it's not all on them, that you're there in that office for them, and you can connect them to someone who can walk with them and be supportive long-term and in the future. I will say one thing to be aware of when you're giving resource referrals is that you aren't necessarily going to see what happens next. You know, you give that referral and the survivor may decide to reach out, or they may decide that that's not the best move for them in that moment. It is completely valid and completely up to the survivor's discretion. They know their experience best. But it can be kind of hard to feel that uncertainty of like not knowing. But you know, you're only with that person for a brief period of time, and so you have to be kind of comfortable with not knowing maybe necessarily an outcome. But it would also be helpful to know, what does a survivor experience when they reach out, so they can manage their expectations. So if you give a referral, maybe to a shelter, there's an intake process. So they'll have to fill out documents, maybe do like an interview. If there is availability, they might have to be put on a wait list for services. You might refer them to our hotline, which is statewide and has a really great resource database for all different kinds of services, which I highly recommend taking advantage of. Is there anything else, Paige, you think folks should be aware of to understand what a survivor will experience when reaching out to services?
I think that what I want to just leave lastly for healthcare providers in this space is to really focus on support, offering those referrals, offering education and resources, and really keep in mind that referring a patient or that person reaching out doesn't mean that they're going to like quote unquote be saved or suddenly be healed or not have the same barriers the next time they're in your office. They may still have those same barriers, or they may have made a different choice, but really leaning into trusting survivors to know what the right next step is for them at the time. So yeah, so just really managing our expectations also helps to provide a continued supportive space, and doesn't end up accidentally closing a door to a survivor.
Absolutely, that's part of that rapport building, letting a survivor make the decisions, drive the car, and move at their own timeline, and just being there to offer support. And you know, when we say believe survivors, we believe what they share about the victimization, and we believe that they know what they need best, and that they're making the best choices for them.
So we're getting near the end of our time today. In fact, we just have a couple more things to share. This first slide is a needs assessment. It is a QR code. When you scan this QR code, the first question will kind of give you a toggle into purposefully different questions. So for example, if you select doula on here, you'll get some different questions that appear. So if you identify as a doula and another kind of provider, please feel free to fill this out twice. So once for each of the identified positions that you hold, in order to collect those perspectives separately in this. So thank you so much for your time on that. And then we wanted to open it back up to y'all to see if you have any lingering questions. Thanks, Elizabeth, for dropping that in the chat. While you're thinking about if you have questions, I'm going to just put up our last slide. Yeah, Elizabeth asked, what was your biggest takeaway? Feel free to drop that in the chat as well. And on this last slide is the info for our hotline that Elizabeth was referring to. That is also available to you as providers if you're looking for resources and have questions too. For folks reaching out as survivors looking for supports, that's not like a time limit on it. It is confidential, and multiple ways that they can reach out, whether they are able to talk on the phone, texting, or utilizing our chat link. Thank you so much for the comments in the chat coming through. Really glad to hear it was helpful. And we are so grateful to each and every one of you for being here with us in this space today and for continuing to share. So if there are things from this space that you know you want to take into your communities, into your to your staff, to other providers, and if there's ways we can further support and help out, that is our email. It comes to all of us that work with this particular grant, and where we will absolutely be able to connect with you further and talk about additional supports. Wrapping up from here, you'll get the PDFs as well as the recording of this will be available. My goodness, will be made available to you. Stumbling over my words. Appreciate you all. Take care.
Thank you.